This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the European Journal of Neurology, set to be published in March 2026. It's titled Long-Term Outcomes and Natural Course of Giant Cerebral Arteriovenous Malformations, Greater than 6 centimeters. Insights from a national multicenter propensity score-matched cohort.
This is a significant piece of work, Alara. We've always struggled with the management of these giant AVMs, those with a maximum diameter exceeding 6 centimeters. They are relatively rare, but represent some of the most challenging cases in our field due to their complex hemodynamics and the high risk of treatment-related morbidity.
Exactly, Dr. Aris. The study comes out of the MATCH registry, the Registry of Multimodality Treatment for Brain Arteriovenous Malformation in mainland China. It's a prospective multicenter registry, and for this specific study, they analyzed 380 patients enrolled between August 2011 and December 2021. The sheer scale of this cohort for giant AVMs is quite impressive.
It really is. To set the stage, these patients had a mean follow-up of 7.3 years. That's a substantial window to observe the natural history and the effects of our interventions. Let's start with the natural history. What did the authors find regarding the rupture risk for these giant lesions?
The numbers are very telling. The overall annual rupture rate was 3.6%. However, when you break it down by presentation, it changes significantly. For those who presented with unruptured AVMs, the annual rupture risk was 2.4%. But for those who had previously experienced a rupture, that risk jumped to 9.4% per year.
That 9.4% is a staggering number for those with a history of hemorrhage. It highlights that once a giant AVM has bled, the natural course becomes much more aggressive. Did the study identify specific anatomical or angioarchitectural features that predicted these hemorrhages?
It did. Using uni and multivariate models, the researchers identified 2 independent risk factors for hemorrhage. First, ventricular involvement, which carried an odds ratio of 3.61. Second, draining vein stenosis, with an odds ratio of 2.61.
Those findings make sense from a hemodynamic perspective. Ventricular involvement often implies a deep-seated component or proximity to fragile ependymal vessels, and draining vein stenosis obviously increases the intranidal pressure, making a blowout more likely.
Right. Now, the meat of the paper is the comparison between interventional treatment and conservative management. Because this wasn't a randomized controlled trial, the authors used propensity score matching, or PSM, to balance the groups. They looked at a primary outcome of long-term hemorrhagic stroke or death.
And this is where the results get controversial, similar to what we saw with the Aruba trial, but specifically tailored to these giant grade 4 and grade 5 type lesions. What did the PSM analysis show?
After matching, they found that interventional treatment did not significantly reduce the risk of hemorrhagic stroke or death compared to conservative management. In fact, intervention was associated with a higher risk of hemorrhagic stroke, with a hazard ratio of 2.04.
A hazard ratio of 2.04 is quite a punch in the gut for those of us who lean toward intervention. It suggests that the act of treating these giant AVMs might be doubling the risk of the very thing we are trying to prevent. Did they look at neurological status as well?
Yes, that was a secondary outcome. Interventional treatment was also associated with a higher rate of neurological deterioration. While the intervention group did achieve a higher obliteration rate, about 39.1%, that anatomical success didn't translate into a clinical benefit for the patients in terms of preventing stroke or death.
It's that classic neurosurgical dilemma. We might cure the imaging by obliterating the nidus, but at what cost to the patient's functional life? Now, interventional treatment is a broad term. Did the study break down the different modalities? I'm curious if microsurgery, embolization, or radiosurgery fared differently.
They did a stratified analysis, and the results were quite nuanced. They found that microsurgery alone and embolization alone were actually less favorable when compared to the group. However, there was a bright spot, the combination of embolization plus radiosurgery. That specific combination seemed to more effectively reduce the risk of hemorrhagic stroke or death compared to other interventional strategies.
That's a very important nuance. For a 6-centimeter lesion, a single-session surgery is often a marathon with high blood loss and the risk of normal perfusion pressure breakthrough. And radiosurgery alone for a giant AVM is often ineffective because of the size limits for delivering a high enough dose. So the volume-staged or dose-staged approach, or using embolization to prune the nidus before radiosurgery, seems to be the more rational pathway if you must intervene.
Exactly. The subgroup analysis also gave us some clear indicators of where we should probably stay away from the OR or the IR suite. The paper suggests that conservative management was significantly preferable for patients with higher Spetzler-Martin grades, those with unruptured AVMs, and those where the nidus was located in eloquent brain regions.
So if I have a patient with an incidental 6.5 centimeter AVM in the motor cortex, a Spetzler-Martin grade 5, the data from this match registry study suggests that my intervention might actually be more dangerous than the 2.4% annual rupture risk they face naturally.
That is exactly what the data suggests. The risks of hemorrhagic stroke and neurological deterioration remain substantial in the interventional group, particularly for those unruptured or eloquently located lesions.
Let's talk about that 39.1% obliteration rate again. In the context of giant AVMs, 39% is actually higher than some might expect, but it's still low compared to smaller AVMs. It means 60% of the treated patients are taking on the procedural risk, but still walking around with a residual nidus.
And that residual nidus remains at risk. The study really emphasizes that the natural course of 3.6% annual rupture risk is the baseline we are trying to beat. If our intervention carries a high immediate morbidity and doesn't rapidly eliminate that 3.6% risk, we aren't helping the patient in the long run.
Did the authors discuss the causes of death or the specific types of hemorrhagic stroke in the intervention group? Was it mostly perioperative or late stage?
The study focused on long-term outcomes over that 7.3-year mean follow-up. While it included perioperative events, the hazard ratio of 2.04 for hemorrhagic stroke suggests that the instability created by partial treatments or the complications of the procedures themselves outweighed the protective effect of partial or complete obliteration in many cases.
This really reinforces the less is more philosophy for giant AVMs. It seems the authors are advocating for a very high threshold for intervention.
They are. The conclusion of the paper is quite clear. Interventional treatment for giant AVMs is not superior to conservative management. They specifically note that the risks of stroke and deterioration are substantial, especially for the high-grade and eloquent cases.
It's a sobering reminder. For our residents and students listening, the takeaway here isn't that we never treat giant AVMs, but that we must be incredibly selective. If the AVM has already ruptured, the annual risk jumps to 9.4%, which might tip the scales toward intervention despite the risks. But for the unruptured giant AVM, the data points strongly toward watchful waiting.
And if you do treat, the data from this cohort suggests that combined embolization and radiosurgery might be the safest of the interventional routes, though still not necessarily superior to doing nothing.
It's also worth noting the risk factors again: ventricular involvement and draining vein stenosis. If I'm following a patient conservatively and I see these features on their imaging, I'm going to be much more concerned about their rupture risk.
Absolutely. The study provides a much-needed framework for counseling these patients. We can now give them real numbers, 2.4% versus 9.4%, and discuss the hazard ratio of intervention based on a large multicenter prospective registry.
This is a landmark study for the match registry. It's hard to get this kind of data on giant AVMs because they are so often excluded from smaller series or treated so heterogeneously.
Before we wrap up, Dr. Aris, any final thoughts on how this changes your practice?
I think it validates the move toward multidisciplinary boards. When you have a giant AVM, you need the surgeon, the interventionalist, and the radiosurgeon in the same room. If the consensus is that we can't achieve safe total obliteration, this paper gives us the evidence to tell the patient that conservative management is not just an option, but often the better option.
Well said. That covers the primary insights from the study on giant cerebral AVMs: a 3.6% annual rupture risk, a higher risk of stroke with intervention, and a caution against treating unruptured, eloquent, or high-grade lesions.
Thank you, Dr. Alara. This has been a great deep dive. To our listeners, you can find the full paper in the March 2026 issue of the European Journal of Neurology.
Thanks for joining us on the Neurosurgery Hub podcast. We'll see you next time.
Goodbye.